We welcome you too, madam. Thank you for your wise words, ma'am. I now request our Honorable Pro Vice Chancellor of Health Sciences, Vikas Dr. Rohan Kharbanda, sir, to kindly introduce the guest speaker.
Good morning, dignitaries on the dais, It is my privilege to introduce our guest speaker for today, Professor Rich. He is president of the Mount Sinai Hospital as well as Mount Sinai Queens in USA.
I was going through his
data. It's very huge, but I would like to summarize in a couple of minutes.
But in one line, if I could say, I would say Professor Reich is a
multi-talented professor. And he is professor of anesthesiology, artificial intelligence, pathology, and also he has done residency in surgery. So I think we can welcome him. Prior to his anesthesiology training, Dr. Rich completed 2 years of residency in surgery, as I mentioned before. He received his Bachelor of Science degree with highest distinction from Pennsylvania State University and his medical degree from Jefferson Medical College of Thomas Jefferson University in Philadelphia. After arriving at Mount Sinai in 1984, Dr. Rich completed his residency in anesthesiology, fellowship in cardiothoracic anesthesia, and much more. His honors, he has multiple honors, so I will try to just speak a few. His honors include 2011 Physician of the Year from Mount Sinai, the Mount Sinai Alumni Association Jacobi Medallion in 2014, the 2021 Heart of the Gold Award from New York Heart Association in 2021 August, Founder Award of the Community Service from CIVITS, and in 2021 again Empire World Health Heroes Award from Empire Blue and Cross Blue Shield, New York. He also received an Pace University 2022 Changemakers Healthcare Award. So Dr. Rich is a changemaker, and I think his lecture is going to bring a big change to our thought process, how we deal with the healthcare. His research interests include neurocognitive outcome following cardiac surgery, medical informatics, and hemodynamics monitoring. He's an academician, clinician, and researcher, having published more than 200 articles and book chapters. He is also an hospital executive, and as an executive, he has focused on enhancing safety and quality by forming an Institute of Critical Care in Medicine. He developed digital innovation tools, including AI-enhanced tools, and a lot of clinical decision support systems. With this brief but impactful introduction of Dr. Rich, I invite him to deliver his talk, please.
I request the dignitaries to kindly take their seat among the audience. Thank you, sir, for giving us such a glowing introduction of our esteemed guest speaker. We now proceed to the much eagerly awaited talk of our distinguished guest speaker of the day, Dr. David Reich.
Okay. Yeah. Oh, yeah, that's very good. Thank you. Yes, excellent. Thank you so much. Yeah. Good morning, everyone. I, first of all, would like to thank the organizers of this conference, Dean Shalini, who was just so very kind and helping me organize this talk. So many of the people who are here on the podium today. Oh, okay. Okay, higher. Okay, so many who are here on the podium today, and all of you who are here in the audience who've taken time out of your day. I hope that you will enjoy and learn, and that we can engage in a very meaningful discussion. For me, coming to talk about technology in the city of Bengaluru is an interesting thing because you might argue it's is a city and a state within India that has achieved so much. So I hope that this is an exchange of ideas and that what we have started at our institution in New York is something that we can work together towards and in the interest of improving the healthcare. And that is why we're here at Ramaiah, because we care so much about the health of people throughout this nation and throughout the world. I have no disclosures related to this particular presentation. And let me begin by talking a little bit about artificial intelligence. Why AI? The rapid rise is unprecedented. It's revolutionizing the healthcare industry, fueling a surge in utilization, innovation, and collaborative ventures just within the Mount Sinai Health System. And so if we think about it in 4 major areas, let's begin by thinking about improved diagnostics. We can analyze medical and patient data with speed and accuracy to provide more precise and timely disease diagnosis. And I would argue without the challenges of humans who get tired and need vacation and sometimes make mistakes. But so does AI. So we have to figure out how to work on that together. Research acceleration. There is no doubt that we will be able to discover new molecules, new trial processes, and to bring research to the next level. Operational efficiencies. We all know that we work in environments that can always be made more effective. Our performance can always be improved. So automating the administrative tasks, optimizing our healthcare workflows, streamline operations, and reduce costs. And finally, for patient experience, think about it. All of us have been through healthcare. All of us have tried to help our family members navigate the very difficult pathways of healthcare. And we should be able, using AI machine learning, to enable patients to receive a more proactive, efficient, and personalized engagement with healthcare providers. So today, I'm going to focus mostly on clinical and operational AI here in the center. Research, not today, and teaching and learning AI, not today, but that is not to diminish either one of those, but in 1 hour, there's only so much one can cover. So I'm going to take you back to an old slide. Anyone who studied population health knows this slide, and I'm sure you see this just as much within Bengaluru as we see it within New York City, in that there is a rising pyramid of risk. And what happens is that we have a group of patients. Sometimes we argue, keep this close. Sometimes we might say that there are many ways that we could establish risk, but we all know that there are patients at the highest risk and they require the greatest amount of our resources and have the greatest propensity to experience harm. And so let's keep that concept in mind as we go through the rest of this lecture. I'm going to begin with something that has nothing to do with artificial intelligence, a simple rule-based tool that we put together to solve a major problem. All of you who are in clinical medicine know that if the level of potassium gets too high, the heart will develop an arrhythmia and will eventually stop, and it will cause death. And this happens in hospitals frequently. We have this because of kidney disease, because of issues related to acidosis, acid within the bloodstream. Many causes of hyperkalemia are present. And within the US, we have a system where the laboratory, when they see a high potassium level, calls the nurse on the patient floor. And then the nurse repeats back the potassium number to the person from the laboratory. And then the nurse is responsible for calling a doctor or another provider, and that provider is then responsible for treating the hyperkalemia or perhaps repeating the blood test because sometimes it could be a mistake, an artifact. Well, unfortunately, the system can break down. Not so much the laboratory. They're very good about calling the nurse. Not so much the nurse. They're very good about calling back and repeating back to the laboratory and calling the doctor. But once the doctor gets it, it doesn't always work so well because the doctor may be covering 20 or 30 patients at night. An emergency might come up. People sometimes just forget. And so what can we do? What we did for this particular problem was we just set a simple, good old-fashioned rule-based system where we send a notification to vocera, which is a voice over internet device, that if no action is taken 60 minutes after the potassium of 6.0 or greater has resulted, we analyzed the time to treatment and we saw that if we continually reminded the nurse through the vocera badge, this voice over internet badge, and this continues to this day, every 30 minutes, something has to happen. And that's the only way to stop the reminders. That simple thing might be repeating the laboratory. That simple thing might be entering orders within the electronic health record to treat the hyperkalemia. And when we did this, what we saw was prior to this BPA, which stands for Best Practice Alert, the mean time to a response was 190 minutes. And with the Best Practice Alert alone, went down to 156 and came down to 145. Initially, when I would make rounds in the hospital, the nurses would say, "This is terrible, so many alerts." But we saw that the number of deaths from hyperkalemia diminished dramatically. In fact, I made a mistake because I said we don't need this in the intensive care units. And although I certainly believe that it's not good to tempt fate, what we do see is that we have only ever seen now one hyperkalemia death at Mount Sinai Hospital since this system started, and that was in the intensive care unit where these alerts were actually not sent. All right, I spent a lot of time on that, and now that we're going to switch a little bit more towards computerization and set ourselves up to start using artificial intelligence to prevent problems in the hospital, to treat them, what we see is first, you have to have the right data, and the data has to flow in the right direction. So let's begin on the left, and you see at the slide, you see ADT, which stands for admission, discharge, and transfer. So that's the database of where every patient is. Epic is the electronic health record we use in many hospitals in the US. Of course, there's also a laboratory system that has those results. And as we move more towards hospitalization in the home, we also have wearables that will display and send information to our central monitoring systems. This comes into an integration gateway. And right in the middle of the slide, we have the most important thing, which is the concept of a data lake. That the data are accessible, and it is accessible. It also pulls information at the bottom from electrocardiogram waveforms, other waveforms like blood pressure, such as we see in the catheterization laboratories, images that we see in radiology. And then towards the right, we move to the concept of machine learning applications that then feed back and give the information that help us improve our operations, our efficiency, and our safety. And that goes to our clinical command center, which keeps track of where patients are within our 8-hospital health system, back to the electronic health record, which I'll say now for the first time, the electronic health record doesn't do any of this AI for us at present. There is a promise it may in the future, but the electronic health record is a platform for us to communicate. And then finally, we have other devices we can communicate through as well, such as smartphones, and again, things like the voice over internet badges. So building AI models requires really 3 things. First, a large database of historical clinical data, something that is coming up in Bengaluru. I see already at Ramaiah discussion. I see digitization of the paper records. And so that is already beginning. Next is the prototyping, development, validation of the algorithms. And finally, it evolves into a predictive engine. And so this is the last slide I promised that shows these sorts of diagrams that you would expect from your computer science colleagues. But you see on the left, There's the data production environment. So where does information come from? Electronic medical record, Internet of Things, and it goes back into that centralized data interface. And then you see it as it moves to the right, the patient data stream goes to the right into the machine learning algorithms. Think of this as our data science environment that makes recommendations, that makes predictions. And then it has to go back. So you see the green AI prediction going back from the machine learning, the inference engine, to the centralized database, and it either uses the electronic health record as a platform communication, or it sends information to people's mobile devices. So at this point, we have a large number of clinical decision support products that are actually in production. And I'm going to go over several of them today, but there are approximately 15 products in 6 hospitals doing approximately 10 million predictions a year at present, but that will only grow. And frankly, it's not so hard to grow because the computers get continuously more powerful and they never tire. So today I'll speak a fair bit about malnutrition, a little bit about delirium, something about patient experience, and something about clinical deterioration. A tiny bit also about something else, which is, I think, yes, patient experience we have. So falls reductions, let's start with that first. There is on the top left here something called the Morse scale. This is a classic scale that nurses use when a patient is admitted to a hospital, and it is used to predict the likelihood of a fall. Remember, a fall is a terrible problem in hospitals. They can result in orthopedic injuries, neurological injuries, and something that we're very much afraid of and work very hard to prevent. And we spend, frankly, a lot of money to have people who observe and sit in the room. We have people who remotely monitor via video cameras, and it is very important that we select the right patients. And then using just good old-fashioned logistic regression, which is also considered machine learning, we were able to improve the area under this receiver-operator characteristic curve. What are these curves? On the y-axis is sensitivity. On the x-axis is 1 minus specificity. Some people think of it as the true positive on the y-axis and the false positive on the x-axis, but I would like to think of it as very simply that if you have that line, the diagonal line in the middle, then it's no better than flipping a coin. It's a 50-50 chance of getting the right answer. So if you have a good predictive model, the area under the curve moves from 0.5 to 0.7 to 0.8. Generally, anything over 0.8 is respectable. Anything over 0.9 is kind of amazing, and over 0.95, you wonder if they made a mistake because it's too good to be true. So what we see here, and what's very important and a lesson to learn, is that when you're introducing clinical decision support, whether that's a hyperkalemia algorithm that I just went over, a simple rule-based one, or something slightly more enhanced, like this enhanced prediction for falls risk, it's important to tell the people in the hospital, the nurses, the doctors, why did we make that prediction? Because you think with your own clinical mind, did this come just out of the blue? Is this something which makes sense? And part of the way to make sense of it is to explain it to people. So if we look at this and we see a patient is restless, we see a patient has inadequate nutrition, moving to the middle, you see that they're on drugs such as antipsychotics, anti-epileptics, anti-anxiety. And we move to the right and we see laboratories such as hypercalcemia, liver function abnormalities, hyponatremia, low white blood cell counts, etc. These are things that people understand. These are markers that say this patient really is sick. This patient really does deserve that. And so what it ended up happening was if you look at the blue with the more slow, and this is sort of, I would describe this as a redistribution of risk. And the fact that the blue bars get lower as you move from left to right, and that the green bars get higher means that we're more accurate. We are not putting precautions on every patient in the hospital. We have now selected the group which is at highest risk, and we can be assured that we're using these expensive resources, people who sit and watch the patients, for exactly the right patients. Now let's talk a little bit about clinical deterioration. All of us who have spent time in a hospital know that it's very hard to look at someone and then 2 hours later come back and see that they suddenly developed a life-threatening complication. That might be sepsis, respiratory or cardiovascular deterioration. It's very upsetting to us. And it is not always obvious to us that this is about to happen. So this is a real problem that we confront day after day. And I'm very happy that just this month in critical care medicine, we were finally able to publish a paper of research that we started in the year before the pandemic and had to stop at the time of the onset of the pandemic. And we used real-time machine learning alerts to prevent escalation of care, basically to find and to treat clinical deterioration before it occurred. And very happy to show you the names of so many colleagues, some of them medical students, by the way, with an interest in machine learning and artificial intelligence, that collaborated with senior doctors and data scientists, and we came together and we said, we can do better. In summary, what we did in the trial was we took 4 of the medical surgical units in the hospital, 2 with primarily medical patients and 2 with primarily surgical patients. And in 2 of those units, we sent alerts that were generated by the artificial intelligence algorithm that predicted clinical deterioration. And that alert, depending upon the level of the alert, was sent either to something we call a rapid response team. Think of that like a special team that runs out of the ICU. You may have heard of, seen in television shows, SWAT teams. I'm not sure how much a SWAT team exists here in Bengaluru, but the concept is that a SWAT team is Special Weapons and Tactics is what it stands for. It's sort of a military and police term, but what we think of it as is a special rapid response team that leaves the intensive care unit. They bring equipment with them, and the idea is that they can save someone on the floor who otherwise might pass away, might die, or might need transfer to an intensive care unit. And we did this in 2,780 patients. And in 2 of these medical surgical units, we generated the alerts, but we didn't send them to anyone. This was an institutional review board approved study. And every patient that was admitted to these floors had the opportunity to say, I don't want to participate. I don't want my data analyzed or sent. Interestingly, no one refused participation. The primary outcome was the incidence of escalation to a higher level of care, and the secondary orders placed for cardiovascular support and combined in-hospital and 30-day mortality. And also we looked at time to ICU escalation and time to discharge. And this is the key slide. And what you see here is that when we look at the escalation rate, we see that we were about 43% more likely to bring a patient on one of these units to a higher level of care, like the intensive care unit. We were 74% more likely in patients who received the alerts to write something in the orders for those patients. And in the most important one in section B there, you see the secondary outcome of combined in-hospital or 30-day mortality, that it was on average 24% less likely for someone to die on those 2 medical units compared to the control units, using techniques to control for the differences in patients between the units. We also saw that patients were discharged from the hospital faster on those units, and that ICU escalations were more likely within 12 and 24 hours. So what do we take away from this? It works. That a clinical deterioration algorithm that activates a rapid response team can save lives. But that's fine. We did a research study. Should we just stop? No, of course not. Every day at Mount Sinai Hospital, one of our intensive care specialists leaves the intensive care unit with a list of 15 patients at Mount Sinai that are at highest risk of deterioration. This is in a hospital that has about 1,000 beds total. And if we take out rehabilitation, obstetrics, and psychiatry, we have about 650 patients in medical surgical. So let's say about 4% of the patients in the hospital every day is visited by an intensive care specialist, and we evaluate them. And so this isn't a study that just was published and ended. This is something that has led to a permanent change in the way that we care for patients in the hospital. Next, let's talk about malnutrition. Malnutrition is incredibly underdiagnosed in US hospitals. I suspect the same may be true here. When we look at severe protein calorie malnutrition, it can happen in someone who is obese. It can happen in someone who comes in otherwise healthy but has, let's say, abdominal surgery and hasn't eaten for 10 days. It is really, really common. And of course, we know from our medical literature that malnutrition is associated with longer hospital stays, reduced resistance to infection, and more mortality. So it's important to treat. And so again, what we have here, this time using a technique called random forest, is we have an artificial intelligence algorithm that again tells the provider, in this case, a registered dietitian, and the registered dietitian sees, oh, the score is high. Why is that score high? Well, there's the BMI, the body mass index, albumin, 1.8, very low. Age, not particularly high. Height, not particularly different than average. Length of stay of this patient, though, 9 days in the hospital. Hemoglobin quite low at 8.2. Remember, normal would be over 12 or 13. Platelet count maybe a little bit elevated, indicating perhaps an inflammatory response. And when you put it all together, it results in a high risk that that patient has malnutrition. And then the other aspect of it, which is very key and something that I think we all have to remember, is what makes an algorithm better is when the team that cares for the patient, in this case, the dietitian, feels engaged in the process. So to achieve something called reinforcement learning, how do we do that? Well, every dietitian who goes out and sees a patient, every intensive care specialist that goes out and sees a patient, they have the ability to give us a thumbs up or a thumbs down, depending upon the likelihood that the algorithm is actually correct. So what you see here is that when they do the documentation in the electronic record, it tells us, was this a true positive or was this a false positive? And so the algorithm runs again and again every few months, and it gets better. And what we see is that this algorithm is pretty good. And this is 6 of our hospitals in the Mount Sinai Health System. Mount Sinai Hospital, Mount Sinai Queens on the left, Mount Sinai Morningside, Mount Sinai West, Mount Sinai Brooklyn, Mount Sinai Beth Israel. And in all of them, we were lucky. We were afraid we might have to run the algorithm separately in the different hospitals, but at least in this case, in our hospitals in New York City, it was equally predictive. And then the most important thing is that the range of the number of people that were diagnosed with malnutrition, if we look at it over the period from 2016 through 2023, it's about 3 times higher. As that didn't mean that we made 3 times more people malnourished, it meant we're 3 times more likely to diagnose it, and more importantly, and to treat it. And within the US healthcare system, it actually results in higher payment, which is very important to us economically because medicine is very challenging in the US economically, as I'm sure it is here. And I'm also very happy to brag for just 1 minute. Last month in June, we won the UCLA Hearst Health Prize for machine learning. It was a national prize, and we beat out MD Anderson Cancer Center. They had an algorithm which I think they said cured cancer. I don't really think it did quite yet, but it was a very nice group, and we actually made friends with them. And last year it was Stanford. And the key point is, if you do this well, and if you make it part of your daily work, people will notice. In this case, an award. Now let's talk about delirium. Delirium is another terrible problem in hospitals. Again, associated with worse outcomes, longer length of stay, and something that you don't see or diagnose as often as you might think, because about 70 to 80% of delirium is not the person who is climbing out of bed and pulling out their intravenous line. 70 to 80% of delirium is subsyndromic or quiet delirium. If you ask the person where they are, ask them who's the Prime Minister of India. If you ask them what date it is, they'll get it completely wrong because they are out of touch with normal facts. They have a severe lack of, I should say, they're unable to show attention to important details. And delirium is a bad thing. And once again, we don't diagnose it so much. The reason I'm presenting this example to you is this is the first one where natural language processing proved to be very helpful to us. In the previous things that I showed you, it was laboratory data, structured data within the electronic health record, information about the demographics of the patient. Now, for the first time, we see that the notes written by the doctors, the notes written by the nurses, the social workers, the physical therapists, those notes provided us incredibly important information. So you can see on the right just examples, fractions or segments or fragments of words that were keywords from the clinical notes in the electronic health record that help make the diagnosis. And as I said before, you have to get a little scared if it gets that high, but we actually tested it. It does work. And so we have a team at Mount Sinai Hospital that goes out and sees patients based upon these predictions, and they do the important things. So many times with patients who are elderly, over 65, we have them on medications that cause delirium. Delirium is often our fault. We caused it because we have the patients on sedatives. We gave them a medication to help them sleep. And various other things within the hospital, again, even things like malnutrition. And so what we saw was, if we look on the right, that before we use natural language processing, the blue line, the red line in version 1.0, 1.1, it had moderately predictive area under the receiver operator characteristic curve. Some people also call that the C statistic, 0.72, 0.73. As soon as we added natural language processing, it jumped to 0.94. So the point here to remember is not that we're so amazing or we're better than anyone else. We're just the same as everyone. We're trying to do the best for our patients. But sometimes the information doesn't just come from laboratory or demographic data. Sometimes the information has to come from what people are writing within their notes, because it is the staff who may not have made the diagnosis, but they're observing key things about the patient that help the artificial intelligence machine learning algorithm to make the diagnosis. Now let's do the final example I'll give you, artificial intelligence to support patient experience. What we did was implemented this between 2021 and 2023 across several hospitals. And it is important within the US because every patient that leaves the hospital in the US gets a questionnaire, which is sent to them electronically, and they rate the hospital. And that is very important for us. It even affects the way the hospitals are paid by the government. It affects the way we're paid by others. So keep in mind here, right now, that it's very important in the US, and I would imagine that it will be important here too at some point. And what we saw was we were able, by sending our patient experience team out to see patients at highest risk and engaging with them, we saw an increase in the number of people that filled out those surveys And it's interesting that when more people fill out the surveys, they generally report better experience. And also we saw that people in the US that are traditionally lower socioeconomic status, people of color, we saw that they were much more likely to participate. So what are the lessons we learned from AI? Don't worry, I'm getting to the end here, so you can get to the point where we ask questions and have fun discussion back and forth. The key is we have the teams. We have the teams in our hospitals. We have the teams in our outpatient clinics. Bring the right team to the right patient at the right time. The AI in our world doesn't make the diagnosis, but it identifies those who are most likely to have the diagnosis. The diagnosis is made by a doctor, by a nurse, by a dietitian, by a psychologist who can diagnose delirium. They're the experts. They are the ones who train, they have the licenses, and they're also responsible. They're responsible professionally, and they're even responsible legally for making the right diagnosis. So let the AI help them. So that's the next point. It isn't artificial intelligence. Think of it as a partnership with the doctors and the nurses. It's augmented intelligence that helps our staff achieve the higher patient safety, quality, experience, and better healthcare economics. And then finally, the electronic health record is not making this happen for us. It is only our platform for communication. Obviously, I think that it's very important that what was supported by government funding in the US to create a system for electronic health, I'd like to see it in many other parts of the world, but not so much because it's important to have a blood pressure on a computer as opposed to on a piece of paper, but what you can do with it. That it sends the data to a centralized database that we can do something with. More importantly, and perhaps most importantly, that we can send information back into the record to get our staff engaged in helping people have better outcomes. So I just want to end with a couple of brief things. Conversational AI is starting to help us, mainly in the world of helping people navigate the very confusing health system in the US, getting appointments, finding locations to a place, checking on symptoms, helping people pay their bills. There are many things that conversational AI can do, and it's actually much better in many ways than our call centers because it has limitless capacity. It doesn't keep you on hold on a telephone. So it's important to see and think about how conversational AI will be very important to patient experience, mostly in providing access, because access is one of the key problems we all face. And think of it as an omni-channel experience that we can do it through mobile apps, through web, and also through our view care option menus. So what have we learned? AI is more than the model. It's about co-designing. There has to be very little distance between the development team, the end users. We have to be agile, start small, optimize the workflow, make sure the team sees it as a positive before we deploy it largely, because if we don't deploy it that way, then the team won't use the predictions. It'll just be part of what's called alarm fatigue. And then finally, robust governance. If we don't do this well, and we train the AI on data that reflect biases, because wealthier people have more access to healthcare. So we might make mistakes because we train the algorithms on people who might be in a better condition to have better outcomes. So making sure there's not bias in the algorithms is one example of how we have to ensure the safe and ethical use of the AI products. And then the last thing we're going to talk about is multimodality. Think about the future. We'll have not just the clinical notes from the electronic health record and waveforms, but we'll have genetic information, the multi-omics. We have imaging information coming together to create harmonized data, predictive models, clinical tools, and most importantly, then on the right, we have validated and calibrated tools that help us with workflow integration and clinical deployment that result in better care for the patients. That's why we're here. We're here for our patients, and we want to do a good job for them. And AI and machine learning can help, but it has to be our partner. It doesn't replace us. It makes us better at what we do. So Ramaiah and Mount Sinai have a new partnership. We're here to celebrate that today. I spent a tremendous time yesterday for several hours touring your amazing campus, both the school, the Ramaiah Memorial Hospital, the Education Learning Center. The resources you have here are spectacular. And you're in a city that's world-renowned for its technology. And when we bring that together with what perhaps we've started at Mount Sinai, and if we take the thoughts that we've begun to bring together and combine it with the tremendous resources that we have here, there's no end to what we can do together. And so I look at this as the beginning of a tremendous partnership and bringing Mount Sinai's ideas, Ramaiah's ideas together in this state, and now the city of Bengaluru gives us tremendous opportunity to do wonderful things. I want to thank you so much for paying attention. Thank you for taking time out of your busy days. I appreciate it.
Anna. Sir is asking any questions from the audience?
David, terrific talk. You took an incredibly complicated conceptual ideas and technology, and you gave a brilliant overview of the potential usefulness of AI and ML. Thank you for that lovely lecture. My question is, in one of these slides you showed that the algorithms that you had developed performed extremely well across all the Sinai hospitals, 8 of them. So the question I have is, although there are 8 different hospitals, they're part of the same system. There is some degree of uniformity. There is some degree of commonality in how you function across all those 8 hospitals. So given how broadly applicable your algorithms will be in hospitals that are not part of the Sinai system?
Thank you. Thank you for raising that. I actually have a bit of a story about that. The electronic health record we work with, Epic, tried to produce an algorithm to predict sepsis. And we ran that algorithm in the background, and it didn't work at all in New York. It was terrible. It was no better than our old-fashioned rule-based algorithm, which actually we still use today because there are regulatory reasons why it's hard to change that. And so today still we look at high respiratory rate, high temperature, low temperature, hypotension, other signs that are classic for sepsis. And why did they fail? Well, they trained the algorithm on a group of people in the Midwest. My joke is corn farmers in Nebraska. And I said actually to the head of AI for that electronic company, well, if you train a data set on a group of people, my joke was corn farmers in Nebraska, it doesn't work so well in the poor people of New York City. And he said, how did you know I used a data set from the Midwest to do this? And the answer was, of course, I didn't. So the answer to your question is, it isn't that we share an algorithm. We share the know-how so that everyone can create local algorithms. It is very easy. What you want to do is you want to share the machine learning engine, and then that has to run on your local data. Because I know there's a lot of diversity in this city. People come from all over India. There's tremendous diversity. If we look at the genomic profiles, I'm sure you'll see a tremendous amount. And you also have tremendous diversity in socioeconomic status here. And so when you take it together, any algorithm I produce at Mount Sinai is destined to fail here at Ramaiah. But it's destined to succeed if we take the know-how and we run the algorithms locally on local data. And we involve the local teams in creating the workflows where we can take the artificial intelligence predictions and work with the local teams. Our joke is, again, maybe it's not such a joke, it's 20% data science and 80% implementation science. Thank you for that question. I should have made it part of the talk.
No, sir. My question to you is two things. I wanted your opinion on that. One is there a risk of over-reliance on AI in the future? Because we don't check our calculator results nowadays. So will doctors be over-reliant and make a mistake? The machine can make a mistake. That is the first question. And the second question is about the risk of AI in general. Jeffrey Hilton, the godfather of AI, has warned us about how the companies are pursuing AI without any checks and balances. So, is that a real doomsday scenario?
Yeah. So first answer to the first question is I'm an anesthesiologist and I do anesthesia for cardiac surgery. And when I started doing that in the 80s and 90s, I would take a needle and I would stick it in the neck and try to find the internal jugular vein so I could start a central. And sometimes I hit the artery, sometimes I hit the vein, sometimes I would hit the lung. There are many examples. There are many examples where. Turn that one off. Thank you. There are many examples where things that we did in the past we no longer do. So, for example, now we use ultrasound, and also within my specialty of anesthesiology, the literature clearly shows that video laryngoscopy is dramatically superior to direct laryngoscopy. And everyone says when we have a new technology, well, we can't stop teaching the old way of doing things. Because if we do that, people will lose their skills. And so no one gives ether anesthesia anymore. No one, except under a dire emergency, starts a central line without ultrasound. And I would argue that it isn't that we're necessarily going to lose our ability to make diagnoses or to treat, but that we will be happy to have the help because we're humans. We get tired. Sometimes when you're caring for people in a hospital, you might have 30 patients, you might have 50 patients. When you're in your clinic, you might see 200 patients in the course of a day, and then you have to remember to check all of their laboratories. So we need help. So I would regard the example of AI as mostly help. We need it and we can get it. And the second and most important thing goes back to what I said before. It's very easy to have bias in AI, so we need governance. We have to make sure that we test continually, that we're never satisfied, that we always know that we can do better, and we always know that in medicine we have a propensity to help, and we also have a propensity to cause harm. So if we never forget those primary lessons, and remember that AI is a tool to help us, that it's really augmented intelligence that makes us better, then I think we will be in a much better place. But I understand the concern that we'll forget how to do it the old way, but we move on. Technology helps us do things better. Technology helps us do things more safely. And it's important to understand that the world is always moving and we have to adapt with it. So I really appreciate that question as well. It resonates for me as someone who has to not just talk about AI, but in some ways to be an evangelist for AI. Thank you.
Hello. Yeah. So it was a wonderful talk. I really enjoyed it. And one of the key points that I saw was that each of the different models you had spoken about were using different machine learning algorithms and different processes. In the future, do we see the furtherment of such individual models, let's say only for parsing X-ray information data, or do we expect a more multimodal AI which can parse various multiple different types of model from EMR to X-rays to IoT device information and then give a predictive analysis, I would say?
Very good. Thank you for that question as well. It's a very, very good one. We started out so early with AI in the mid 2000 teens that we called it big data. No one was even using AI. In fact, I made a joke again. I make all these jokes. No one ever laughs at them. I called it my little big data group when I started out because there were just a few of us and we wanted everyone from the school to come together and talk about ways of doing things. So where we started with logistic regression, random forest, et cetera, was very important at the beginning because we had to explain to people how we made those predictions. As we get more used to it, as we trust it, as it proves itself over time, that will be less important because we'll know from experience that the predictions are accurate and reliable, and of course, hopefully also unbiased. So let us keep in mind that the models will evolve, technology will evolve, convolutional deep learning is something which is going to completely revolutionize so many things happen in this world. From the way you interact with any company that you're buying a product from, when you browse online, and of course, the way we practice medicine. So I think the key point that you've raised is one that the technology that we started with is not the technology we're going to have 5 years and 10 years from now, because things move along very quickly. But I think the important lesson is in the early phase, you have to build up the confidence of your team that you're doing the right thing, that you're helping them. So the way that we begin and the way that we grow is not perhaps where we end up. Thank you. Yeah, there goes. Yeah.
Thank you. That was a wonderful talk, very lucid. And I'm Deepa again. Quick question of how do you do is there a continuous feedback loop that you use in some of the AI software? In terms of monitoring, you mentioned the regression, predictive capabilities all the way from 81% and 95 is sort of an alarm bell.
Yeah.
So how do you incorporate to say that there is variability in the predictions and hence the risk of, wrong predictions? Is there some algorithm, does it incorporate that between multiple hospitals in Mount Sinai?
Yeah.
That's the first question. The second is like what we call the probability of failure. How do you address that? Because it's
Sorry, probability of
the probability of failure,
Yeah.
in the predictions using the AI. How do you address that?
Your question is a very good one because when you think about what makes us get better, if you might think of it as a partnership between humans and computers. So if we start with an algorithm that's based upon historical data, in this case, let's go back to malnutrition, and the dietitian goes out and the dietitian sees the patient, well, there are really only two possibilities. They have malnutrition or they don't. The only thing we're really missing are the false negatives, the people who had the malnutrition that we might have missed. But some of them might be found by other means. So every few months, we rerun the algorithm. So I wouldn't say it's continuous, I'd say it's continual or intermittent, in that what we do is we let the people who are on the front lines of medicine, they tell us if we did a good job or a bad job with every prediction. So reinforcement learning, in my opinion, has to be a key thing that we deal with. And variability, mistakes, well, they will happen. But that's why we look at this not as making a diagnosis, it's making a prediction of a diagnosis. It's up to us to diagnose and to treat and to do it well. There will be a time in the future where there will be accurate diagnosis by AI. In fact, that may not be so far off. But so far, large language models, which I haven't really addressed today, when they make a mistake, we call it hallucinations. It's just a mistake, just a fancy name for a mistake. And so we have to understand in this early phase, there will be many mistakes. And we are the safety barrier. We are the protection. We are the shield. And we can still make use of these early algorithms and do very well. but we have to understand that it's not perfect, and it's our job to work with the teams that produce the algorithms to make it better every single time. Thank you.
So may I ask you a question?
Sure.
My name is Harbinder and I represent Business World Healthcare.
Yeah.
I'm so glad that you used the term augmented reality rather than using augmented intelligence rather than using it as artificial intelligence. Because going forward, probably the next step could be where AI is going to be taking action and creating stuff,
Yeah.
right? Healthcare is based on the faith that people have on the doctor and on the medical delivery mechanism. Now, will there be a time when we'll be over reliant on AI and blindly focus on it rather than using our own intelligence? And would that be a risk for the patient? Because the whole idea of bringing AI is to reduce the negligence. But we are all human beings, so are the doctors. If they become over reliant on AI, that could actually increase the risk of negligence. How do we control the messaging to the medical community so that they need to be conscious while using it as a help and not just be blindly relying on it?
It's again, a very good question. I don't have it in this talk, but there is a study that was done in mammography predictions. And what they did was they had three groups of people: residents who were very junior, very inexperienced, moderately experienced, and senior radiologists that were very much at the top of their game. And then what they did was they used an AI algorithm to predict whether there was a lesion that might require a biopsy, perhaps even diagnosed as very high risk for cancer. And then they introduced intentional mistakes. And what they found was that when they were using the system, that the very junior people, when there were intentional mistakes, were swayed to make the wrong diagnosis. Exactly your point. The moderate level people were sort of in between, and the senior level people were much less likely to be swayed. And they said, the computer's wrong, I know better. And so, yes, it's a risk. But once again, I think it goes back to the response I gave to the other gentleman. I no longer use ether, never did. I don't know how to give ether. I don't know, I know how to do a central line without an ultrasound. I know how to do a laryngoscopy direct without a video. But I can be better if I use these tools. So I think it's also a matter of overcoming our own fear of becoming obsolescent. How do these computer systems get better? It's only by working with us. It's only by helping us. And, there will be things that will be much better for a computer to do. Perhaps instead of someone coming to an emergency room, they speak to an AI chatbot and it looks at their symptoms and it tells them whether to come to an emergency room or not. If it does it well, it enables those people in the emergency room to do their job better because they'll be taking care of the people that actually need them and not worried about the 20 other people who are sitting there in the waiting room who basically just needed to be told they're okay, or to take some ibuprofen and call me in the morning, is the old joke, right? So think about it this way. We can say, technology is going to replace us. We shouldn't, enhance it or work with it. Or we can say we need to embrace the future. And so I think the answer has to be, we can be appropriately concerned, but we won't lose our skills. Our skills actually, in my opinion, will get better.
Yeah, David, I have two questions, somewhat related, but not really. So how is Sinai? I mean, you got a world-class medical school as well. How are you integrating these AI ML concepts in our medical curriculum? Because they're already overwhelmed with what we teach them in 4 years.
Mm-hmm.
And so, number one, how are you inculcating this knowledge as part of your medical school curriculum, or even in our training fellowships and whatnot as well? And the second question, completely unrelated, is reflecting on the question the other gentleman asked about multimodal, diagnostic tools, where you can integrate the information and come up with,
Sorry, what,
diagnosis. Multimodal.
multimodal, yeah.
So everybody talks about AI, ML is the future, but I think the future is already here.
Mhm.
So what do you think the potential implications of quantum computing? It's around the corner already, and how it would impact upon, everything that we are doing while this is all fantastic and helping us a lot.
Mhm.
And everybody tells me the quantum computing is going to completely change the way we're going to look at everything. So I just would love to hear your
Okay,
sense
yeah.
about.
Let me start by saying that I really have no doubt that medical education will be revolutionized by AI. Already, although I was extremely impressed by seeing the laboratories here, especially the dissection laboratories, there is no more smell of formaldehyde for Mount Sinai medical students. They do all of their anatomy learning virtually through simulations that are done and show the relationships to everything. They don't do the dissections anymore, except, of course, there are surgical education courses where it's very helpful in training people. But the classic medical education is also changing over time, and that's probably a good thing. In the US, it's much harder. Here, I'm just beyond impressed by the ability you have of obtaining donations so that you can learn in that fashion. And I don't doubt that there will be a tremendous amount of ability to revolutionize the rest of it, a lot of the lectures that are given, a lot of the laboratories. But I don't claim to be an expert in AI for medical education, but have no doubt, of course, that will help us, because think about all the times when you were searching a topic, you had to go to the library before the internet and had to look it up in Index Medicus. Then you took notes and then you had to try to find the articles, maybe you Xerox them, and now you can do it all online. So look at it as a continual evolution. Technology will revolutionize the way we teach, as well as the way we provide medicine. And I would also argue the operations, because I didn't talk about it so much today, but there's so much inefficiency, supplies that we can't find, so things that we've over-ordered, under-ordered, efficiency of processes like getting a room cleaned and getting a patient up to a room from a crowded emergency department. There are performance improvement opportunities everywhere we look. And so technology is the promise. It's our responsibility, though, to make sure we do it responsibly and accurately, so that when we train those medical students, we train them well, and that when we improve those processes, we make them better, not worse. Thank you.
Our budding students at the back, do we have any questions from the audience?
My question is related more towards the conversational AI, because I feel that also has a lot of potential for the healthcare sector, right? So how to make this data sets, basically the kind of like
How to make the data what?
these data sets basically for conversational AI contextual in nature, so that it helps more to predict certain things, just like we are based on our pitch and loudness and all. So can you give some light on that one? That would be better.
Sorry,
How this conversational AI can be utilized. Right.
Thank you, yeah. Yeah, conversational AI is actually very important to us, and we're starting to use it now. One of the biggest problems we have in my health system is having people get access to the doctors, to get in, to have an appointment with the appropriate specialist, and not to get dropped in the system, not to make an appointment, but someone cancels the appointment and it's not communicated, not to have to wait 4 months to see a neurologist, for example. And so what conversational AI has helped us do is move beyond the concept that you have to call in and speak to an assistant who does the scheduling for the doctor. And you find a way to make the process more efficient. You find a way to reduce the errors. Thank you.
Questions from the students?
Students have another class.
Hello. Yeah, my question to you would be, would you say there's a higher requirement for AI in, say, live data processing or static data like a lab result for some patient?
I'm sorry, like lab?
My question is consider live data being fed into an AI algorithm.
Yeah, live.
Would you say there's a higher requirement in a live data situation or observing trends in static data?
I think that, I'll give an example of where I think live data will be most important. Let's say surgical procedures. Let's say, Dr. Sharma, who is here from New York with me, he's an expert in catheterization. The imaging that he obtains in the procedure guides the way he does things. And we're all human again, and you can have someone who's the top of their field, but they might be about to make a mistake. For example, right now, neurosurgeons at Mount Sinai operate with a special microscope that has a 3D model of the tumor that they're trying to resect, which is underneath the image of what they're actually seeing surgically. So they have an idea how many millimeters away they might be from an important artery or other structure. So I believe that the live data streams that you're talking about will be based largely in the surgical and procedural realms, but also an extremely important application. Thank you for asking that.
A follow-up on the health, the medical education about AI question. The one thing which I would see is there are multiple people developing models for a single use case. In the sense, for chest X-ray analysis, you might have models developed by Mount Sinai, by Harvard, Stanford, and so many other medical colleges or universities across the world. As medical doctors, do you think educational upskilling will be required to better understand research when trying to choose which model would work effectively in a setup which we want to deploy it in?
Mhm. I think the selection of models is most important. I think of it as a partnership. When you're a doctor, you decide which medication to use. You decide which procedure to recommend. And in a real world partnership where we realize that, again, I make all these jokes no one ever laughs at, that we're really in medicine, we're a tech industry, but we just never realized it yet. So think of it as a partnership. You work with a data scientist and they prescribe the tool which is best suited for the data set that is presented to them at that particular time. And then you, on the other hand, as they start to produce from data science, they start to produce predictions or modeling, you have to say, this makes sense to me or doesn't make sense to me as a clinician. So just think about it again as partnerships. In the past, we're doctors working alone. We think that we have independent and depend on no one else to make the right decision because that's how we're trained. In the future, perhaps it's more of a partnership. Thank you.
Thank you. That would be the last question of the day. Thank you, sir. Thank you for engaging our audience and keep them in such rapt attention. Calls for a round of applause from the audience, please. I now would like to invite our Honorable Pro Vice Chancellor, sir, and respected Principal and Dean, Madam, to kindly felicitate our speaker for delivering such a wonderful talk. And it has been an incredible experience, sir, listening about your experiences and the kind of impact that you have had in your work. I also request Dr. Madan Gaikwad, sir, Chief Operating Officer, Ramaiah Memorial Hospital, to kindly join us on the dais. I request sir to propose a vote of thanks. So could you please come forward?